All right, paper 5. So let's talk about paper 5 quickly before we talk about any of the problems that you experienced in paper 4. And I do want to make sure that I talk to you about the problems in paper 4 because, some papers I had to send back to you because they did not meet the AMA standards. Now, well, if you've got any other questions or issues that you want to bring up about paper number 4, things that you saw happening in your paper, things you didn't quite understand, I'll be happy to handle those questions at any point in time. If you want to wait until after class, that's fine too. But I think that I've got a list in my head of a couple of things that I want to talk to you about that I think we can all learn from, so that paper number 5 comes in as strong as it can be. So let's talk about paper 5 in general. So I need you to do the same thing that you did in paper 4. I need you to find a condition. I need you to think about it. I need you to read about it. I need you to be able to come up with an operational definition. In other words, where do we need to see treatment options in order for us to declare efficacy, right? You need to be able to justify that. So essentially, your reading and research, background information, anything you can come up with to help you critically evaluate your condition so that you know how to set a standard. And I'm doing this because, under time constraints, because now, this is really the focus of this whole course is to get you to this point so that now you can say, all right, if I'm going to learn something about a topic, I need to go out and think about it in these ways, right? So you know where to go, you know how to, sift through the information, you can kind of get to it quickly so that you can pull together your ideas in a reasonable amount of time, so that you can make some good decisions about treatments. The pressure of doing it in a week and writing this kind of paper, though, is kind of an added effect in that, you really have to be able to go out there now and, find research quickly and be able to make good decisions about the research quickly. And this is one of the things that was lacking in paper 4, I thought, was the evaluative assessments of the research. And we'll talk about that in a minute. So you need to make sure that you do the good thinking and the background reading and the critical analysis of the condition so that you know how to set an operational definition. And like we did last time, I need you to talk about the various treatment options that are out there and exclude certain treatment options. Now, this is something that you need to, to think about as well. A lot of people on paper 4 found one study that was faulty and decided that they were going to throw an entire science in the garbage, right, based on one study, right? That's not reasonable. So what you need to be doing is you need to be looking for the best possible studies that you can about that particular treatment option, right, so that you can kind of breeze through them to find out why they're not meeting your standards. So maybe it's because there isn't enough research base to make an informed opinion about it. Maybe the research isn't well controlled. That's certainly a factor. But we don't ever make decisions in medical science based on one study. So excluding a study in your introduction based on one crappy, scientific study that you found, right, is unreasonable, right? That doesn't make any sense. So you need to be able to think about, what you're writing, right, what you're claiming, so that you're making an informed decision. If it means, digging around in a variety of different sources about all these different treatment options, great. As I said before, the best place to go to help you sift through all of this is Cochrane, right? Cochrane's going to be the place that is, going to show you probably where the more legitimate treatment options rest, right? So they're going to show you what's out there. They're going to do a lot of the comparing for you, but more importantly, they're going to be talking about the different criteria that they used to make that decision, all right? So your heavy lifting, is done for you a little bit through Cochrane. So getting back to that introduction, read, understand your condition, come up with an operational definition, start looking at all the different treatment options out there so that you can break it down to the 2 best treatment options that you can now compare, making sure that those treatment options are comparable, right? Meaning that they're both treating the same patient condition, right? That they're same level of patients with the same type of condition. Don't try to compare a patient with a severe condition versus someone who's got a mild condition. The treatments are different for those particular categories, right? So just make sure that they're comparable treatments, and then come up with a thesis statement that A is better than B, B is better than A and B are both equally efficacious, or A and B are both equally inefficacious. You have 4 different options that you can choose for your thesis. All right, so any questions about the introduction? I mean, it's something that you did already with paper 4. If you struggled with the introduction in paper 4, now is the time to ask questions about it. Everybody good with what you're doing with paper 4, right? Or with how to narrow this thing down and to get it started, right? Now, I've seen some introductions that were 3 to 4 pages in length, which is pretty much standard, right? I saw some that were quicker, right? Some that were a page in length, simply because there were so few treatment options available, right? It's okay. If that happens, that happens. So I would also, in your position, start thinking about a treatment or a condition, something that you're interested in, right? Because it's a lot easier to read about something that you're taking an interest in, but certainly it has to be something that is relevant to your profession. For those of you who are in the PT program, you're taking PT 312 next, you have to do a presentation on the research that you're doing in this class, right? So you need to do a presentation on something that is PT related. So make sure that you're looking at musculoskeletal conditions, right? If you go to Cochrane, you can see musculoskeletal right down the left-hand margin. Just go click on that, and it'll talk, bring up a whole bunch of conditions that are musculoskeletal related. All right. The body paragraphs then, just like we did last time, going through and making the assessments based on the criteria that you've established in your operational definition. So if it's range of motion, you're going to have a paragraph about range of motion, but then you're going to go out and you're going to find as much research as you possibly can about your treatment options and those particular categories. As I said, there's a variety of different things that I saw going wrong with paper 4, and there were really two major problems that I saw. One was a lack of evaluation, right? So when I say lack of evaluation, what I mean is that we know that 80% of everything that's published out there is going to be weak, right? So the randomized controlled trials are your strongest evidence. Your reviews are your strongest evidence, your systematic reviews and your kind of comparison articles, right? Where scientists are comparing data from a bunch of different articles that are already written and published. So those are your strongest forms of evidence. You know that there are weaker forms of evidence out there, right? So the question now becomes, right, how do I manage this? Well, you manage it by understanding that certain studies are going to be held to a higher standard simply because they have more information validity, right? So if you're going to be talking about validity, then you've got to make sure that's part of the conversation, right? I mean, you can't have a conversation about just clinical data, right? And this is one of the things that I was just banging my head on the desk when I was reading your papers, right? Was that you were going through and you were reporting what was going on clinically, but without the statistics behind it, the clinical values don't mean anything, right? I mean, the stats verify that the treatment caused the outcome, right? Now, you don't have to have lengthy conversations about the stats other than to say, parenthetically, P is less than 0.05, or the confidence interval was 95%. Just put that in parentheses. You don't have to do anything else. If P is above 0.05, or if the confidence interval isn't 95%, or if your standard deviations cross each other, right? Well, now there's probably time to have a conversation right there about the issues that raises, right? Because if you don't have the statistical validation of the data, then there's no sense in trying to lay claim that the data are effective in making your argument for you, right? I mean, look, let's go back a second. This is just me talking, right? I don't know, maybe I'm crazy, right? But if I hear someone saying something that I know is wrong, why would I support that? I don't know, right? That doesn't make sense to me, that if you have studies that just have clinical data and they don't report any statistical data, right, then you can't support that, right? You've got to look at that and say, look, this is just low-level evidence showing that there's a trend here, right? That's all the credit you can give that. You cannot stand and say, hey, look, they reduced pain to the level that I was looking for. There's no stats involved here, but we're going to support it anyways. That's insane, right? That's like the crazy guy in Top's parking lot telling you that the world's going to end. You're going to go home and start selling all your possessions because you think the world's going to end? No, this guy's crazy, right? Why would you listen to somebody who's crazy? Look, all they're doing in those low-level studies is making an assessment that there may be fire, and they're going to show you the smoke. That's all they're doing. Right? They're low-level studies that are just trying to establish that there's something going on there. Right? You've got to look at those numbers, and many of you started writing in your papers about the numbers of patients in the populations. And I'm sitting there going, what's the relevance of the numbers of the patients in the population? Right? Why would I care to know the numbers? Well, if the numbers are below 30, remember, for every variable that you study in science, 30 is pretty much the minimum number that you're going to need in order to produce statistical validation, right? So if you have more than 2 variables being studied, then they've got to have 60 patients, or they've got to have 90 if there's 3. Obviously, the numbers shake out in different ways for different conditions, but that's generally the way we think about things, right? If 30 is the cutoff, because that can provide us randomization, right? 30 is the number that can provide us the randomization. If your study doesn't have 30 patients for each individual variable, right, and they're not reporting statistics, well, then you can pretty much say, well, that's obvious, right? They didn't have enough patients to run a power analysis, so they can't do any stats on this, right? So all you're going to do is give that a little bit of credit by saying, hey, they're just out there showing that there may be something here. This isn't science that's giving us proof, right? This is nothing more than science that's giving us low-level evidence, right? That's how you need to present that information. I can't tell you how many times I read over the last couple of days when I'm reading these papers, people making assessments. Oh, well, they had the clinical numbers that met my standard. Their statistics were, off the charts, invalid, but we're going to support it anyways because they got the clinical numbers. And I'm going, how could you possibly do that, right? That doesn't make any sense. Why would you try to support something that doesn't have any validation? Am I making myself clear here? Because I thought I had this conversation last week, and for some reason, I got papers that didn't have any discussion of stats in them at all. I don't know what I'm supposed to do with that, right? I just throw my hands up in the air and, say I don't know what to do, right? I mean, you need to understand that the conversations we're having need to be on the clinical numbers and the statistical validations, right? Because without the stats, the clinical numbers don't mean anything. Another issue that I found that was very problematic in the papers, right, not only the evaluation of the studies, right, was the correlation of the studies, right? If you find yourself writing a sentence that says, Jones et al. Conducted a study, you need to highlight that, put a note to yourself and say this has to change, right? All researchers conduct studies. If you write that sentence, you're telling me that the sky is blue and the grass is green, right? That's obvious. We know that researchers conduct studies. This is chapter 4, right? We're going to have to go spend some time in chapter 4 in the text dealing with the management of information, right? A lot of times, because we get bogged down in trying to do the critical thinking with all of these studies, we fail to see the big picture. We fail to see how to make information move across the paragraph. We tend to just revert back to the short, choppy sentences. These guys did this, these guys did that. This is what we found. This is what we didn't find. This is what the answer is, right? That's how we end up just kind of just blurting out this information in short, choppy sentence structure. You still need to write, right? You still need to control your audience. You still need to maintain your audience's interest by moving information across the page. Transitional elements, right? Keeping things correlated. Correlation means, right, that you're taking a look at the outcomes of the studies. The whole reason you're having conversations about any of these studies is because of what they found, right? So to write a sentence that they conducted a study is telling me nothing, right? They conducted a study on whatever. So what? Just get to the point. Tell me that Jones, in their study on such and such, just determined that this was better than that based on these data, right? Get to the point. Don't fill your paper with a bunch of meaningless information about details from the study if the details in the study aren't relevant to the whole argument, the conversation that we're having, right? My point is that you need to be focused on sentences that say the author accomplished a task. They found this. They determined that. They, with these variables, found some reliability, some clinical significances. Get to those points, right? So keep that in mind and keep the information moving. That's the easiest way to correlate your sources. So when you establish that Jones did this in his study and found this bit of information, when you begin a new study, you can say Smith found something similar to Jones or found something completely different than Jones, so that you can show how Smith's research reacts with Jones' research. Do you understand what I'm talking about here? You're trying to correlate the sources. You're having a conversation about what all of the research means, so that by the time we get to the end of that paragraph, there's a clear focus of ideas that's running across the paragraph, getting me to a conclusion of some kind. If I read, this guy conducted a study, here's a bunch of data. This guy conducted a study, here's a bunch of data. This guy conducted a study, here's a bunch of data. How is my brain supposed to wrap around that, right? There's no way. I can't retain all of that information. You need to be doing the comparing and the associating throughout the whole paragraph. Some of you are better at this than others. We're still learning this process. It's a reason why I do 2 research papers, because you take paper number 4 and you have your struggles there, but with paper number 5, you got to hit a home run with this one, right? This is the one that you got to really do well on. So keep those 2 ideas in mind. Evaluation of the source material, in other words, raising up the stronger studies, minimizing the weaker studies, being willing to say, hey, this is low-level evidence, this is strong evidence-based science here, right? I mean, that's what you need to be doing throughout these paragraphs. So that by the time you get to the end of that particular section, however many paragraphs that is, whatever you're doing, that you can come to some kind of conclusion, move on to your next criterion, and do the same thing, and move systematically through the paper. What's going to be different about this paper than what was paper number 4 is that the conclusion to this paper is going to be a 2-pronged conclusion. Your first part of your conclusion is going to focus on just summarizing what your subsections ultimately accomplish. In other words, so if you looked at the data from all of your studies and you had all of your kind of mini arguments in each of your subsections of your paper, your conclusion is that treatment A is better than treatment B based on whatever, right? So you're going to summarize it up in a normal conclusion. What we ultimately need to do then is we need to be able to write a projection of future research paragraph from that. Right? I'm assuming that you are not going to have clear-cut answers in your research, right? You're going to have problem areas. You're going to find that there's certain parts of the science that are stronger or weaker than others, right? So at this point in time, in this conclusion, that's where I need you to have that conversation about where future research needs to go, right? In other words, I need you to start putting into perspective what were the areas of weakness in the studies that would warrant more research. In other words, if you take a look at any of the scientific articles that you've read, I'm sure people have done the same thing in all of those. In their conclusions, they talk about, hey, where's future research need to go? So this is what you need to do. You need to be able to say, based on everything that I've read and all the data that I've collected here, we've got some pretty good answers in this arena, but we don't have them in this arena, right? So that's what your conclusion does. Your conclusion is, here's what we know. This is how we're going to make a decision, but here's what we don't know. And this is why we've got to do better research over in these areas, right? So a paragraph or 2 or 3 or whatever it takes in order to get us to a focus on where the current research can lead us in the future, right? Where does research need to move from this point in order to get us some better answers? So it would be illogical. Let's just start with the problems, right? If you're going to go through and say that you've made conclusions that this particular treatment option achieves its goal and reduces pain, and we've got the answer to the problem right here, right? It would be illogical for you to suggest more research about that treatment option and its focus on pain, because you just got done telling me that the argument's already over. You understand what I'm saying? Right? So to project things that you've already established answers for, right, would be foolish, misdirected. Obviously, the research isn't perfect. Obviously, the answers aren't clear out there. So what you should be doing is, through the course of your research, be honest about what the data actually tell you, right? So that you can say, hey, we've kind of got some certainty here, but we don't have maybe these kind of things. So maybe there's reason why we need to do more research here. But if you come out and say, this was the definitive answer, that this one is outperforming that one, then I'm going to say, what do we need to do more research for? Obviously, there are some areas that need additional research. Maybe you get to a point where you're looking at your studies and you're looking at the treatment options that you've got, and if neither one of them are reaching the goal, right, the operational definite, well, then where does research go in that case? We didn't keep pouring more money and time into studies about treatment options that we already know aren't working effectively. Why aren't they working effectively? Is it because our science isn't good enough to measure them, or is it because the treatments themselves actually aren't effective? It's a good question, right? Because now what do we do in that situation? Do we abandon those treatment options? Do we just say, hey, we got to stop using this stuff, we got to start going in different directions? Maybe there's promise in some other type of treatments out there that haven't just been scientifically validated yet. So that may take you back to your introduction where you're talking, I know that this has happened, time is key across research, right? When new treatments and new ideas come around, things start to be implemented, right? If the research isn't out there, people aren't willing to jump on board with that stuff until there's more definitive studies on it, right? So a lot of times we'll start to see treatments being employed and we'll see some low-level research out there. And if it's showing promise, well then, why don't we go stick some research time and effort behind that, right? If that's going to get us better results than what we're currently doing, then it makes sense. Let's go pursue that. But if the results aren't any better in those new and different treatments that are out there, if it's just more of the same, why would we want to go spend time and money to research it? We would want to put our time and effort into something that has a better chance of producing effective outcomes. Now, that's the chicken and the egg problem though, right? How do we know if it can produce better outcomes if we don't study it? Put it into a scientific environment and let's analyze it. Sometimes that's what we have to do. We have to just try to figure some things out. It's the reason why Benson gets paid, millions of dollars to go do research on intercessory prayer, because people in the sciences are standing around going, well, no one's really studied it in this environment before, so let's try it out. Let's see what he can get. Makes sense, right? We know what the answer is probably going to be, but let's put it through the scientific test and see if we can figure out if he's, get something unique or different. So this is the difference between paper 4 and paper 5. And that conclusion, just let me tell you this. That conclusion is a clear indication to me that you have your head wrapped firmly around the state of research in that field, right? If your ideas aren't clear, if your projections of future research are all over the place or inconsistent with what you've been writing throughout your paper, right? It tells me that you're just coming up with any fanciful idea you can come up with to throw something down in a conclusion to meet the general requirements of this assignment, right? That's not the whole purpose of doing this, right? We're training you to be professionals. We need you to be able to understand your field, right? If you know your research well, if you know what the research says, if you know what the strengths and weaknesses are of the bodies of research that you're reading, you will be able to write an informed conclusion here. This will make sense to you. You will be able to say, yeah, you know what? We really don't know what this means over here. So let's pursue this. or we need to throw this treatment out and go after something different. That tells me that you've got a good understanding of your topic. Yes.
So for the projections and everything, like a couple of the papers I read had a lot of different variations on how they were testing range of motion. So like standardization.
Yeah, that's a great idea. Can I interrupt you for a second about that? Because look, I think that many of you have just, because there is a test and measure out there, have automatically assumed that that test and measure is perfect. And they're not. We know that they're not perfect. And I think this is what you wrote about in range of motion, like they were studying with tape measures, and I mean, there's things like goniometer and that kind of stuff, right? I mean, there's different things that show, distance and measure angles and those kind of things. But what do they really mean, right? The get up and go test, the 6-minute walk test, the WOMAC test, are those, I mean, sure, they have been validated, right? Meaning that if you apply the test in the same way to the same groups of people, that we pretty much get the same types of outcomes, right? Does it mean that they're a perfect measure for what we're trying to accomplish? No, but they're validated, right? I mean, people, are constantly, some people are writing this, well, the way to study pain is the VAS scale. No, it's not. It's just one way of studying pain. The VAS is just, people putting marks on a line. It doesn't necessarily mean that it's accurate, and that's the reason why statistics are important with things like the VAS scale, right? Sure, it's subjective. Everybody's going to measure pain differently, but we don't care about the individual scores. What we care about is the group, because if the whole group is moving down the scale, right, because of treatment, well, then we can validate that the treatment was the thing that caused that movement. If we take into account all the other variables that people are, have got in their lives, the only thing that we could probably attribute that change to is the treatment. So the individual scores don't matter. It's the group scores. And that's why stats need to become part of the conversation. But it doesn't necessarily mean that the VAS is the right way to study pain. And this is a thing that just, you could probably write your entire conclusion on the systems of tests and measures that are out there to say, we got to get better tools to measure all of this. I don't know if that's where you were going with that. Yeah, Alex, but so tests and measures are certainly fair game. If we don't have good tests and measures, we got to come up with some better ones, right? You should, for every test, when a study starts writing, when it's the methodology section, right, their methods, and you start looking at what they're doing in there, right, you need to be scrutinizing those methods. You need to be looking and asking questions. Why did they do this? Why did they use that tool? Or why did they use this particular group of patients? Or how did they come up with this, system of randomization? Or how did they come up with this, group of patients for, how come they didn't control for these variables, right? That's the questions you should be asking, right? You don't just read it and accept it, right? Because you know that everything that's written out there is going to be faulty to an extent, which takes me to a whole different level here. I mean, just because we know that everything can be faulty doesn't mean that we reject everything either, right? Let's just put a lid on this a little bit, right? That we can't, just because we know that there's no perfect study doesn't mean that we throw it all in the garbage, right? We know that some things are better than others. Some things are going to give us reliability that, to the best of our knowledge, 95% certainty is all we can get. So if that's what we're getting, if you're meeting your clinical standard and you're getting the stats that are showing that 95% certainty, well then that's as good as it gets. How can you get anything better? So that's what you kind of put your stock in and just say, okay, there's going to be variability. We know that out of the 95%, if we take 100 patients, we might have 5 outliers. So what? Doesn't mean that everybody's going to be treated the same way with the same, outcomes. All we know is that there's variability in the human condition. That's one thing we can be sure of in all of this. You're humans, so nobody's the same. Any other questions about what we're doing, where we're going, and how we're going to get there? Topics. What have you started thinking about?
Scoliosis.
Scoliosis. Okay. You want to explain it to the class for anybody who doesn't know what scoliosis is?
It's a deviation of the spine, and a lot of the problems I found when I was doing acute low back pain was just the causality for having acute back pain, but scoliosis, it can be degenerative. There's a lot of other variables that are involved. It just seems to be more concise way to measure something. There would be a more concise way to measure scoliosis than
Cobb angles and
Yeah.
those kind of things, right? That we know that curvature of the spine should meet a certain standard, right? So in a way, it's a very measurable condition, right? That we know that, hey, so historically, the treatment has been bracing, right? And there's different types of braces out there for people going through, especially those final years of their growth, right? I mean, that trying to straighten out the Cobb angles at, times when it's usually females, around the ages of about 13, whatever, they start, putting all this, into practice. Okay, but that makes sense. But what if we don't treat it at all? What happens?
most of the times it can progress to a worsened condition.
Okay, can it correct itself though?
In some cases, yes.
Right. In some cases, yes. Right. So there's variability in it. We know that, and so there's going to be certain cases that are more severe than others. Right. How do we classify those? How do we know who's got the more severe cases when we start our studies? Probably don't. So it adds a level of variability into your conversation. Look, I mean, you're laughing about this like, I'm not out to get you, right? I mean, I'm not out to just, say, well, there's a fault in your argument. That's not the point at all. The point is that I need you to be critically thinking about, everything that you read so that you're making good judgments about this, so that when you see bad things happen in the research, you can look at the pool, the data collection, how do we get our, how do we screen for our patients? And you can say, well, if we really didn't screen carefully for these, then that's the reason why we might get some outliers in our study. Yeah, and so that's the conversation that you need to have in there. But if you're not thinking about that, if you don't know enough about that, well, then you're just going to run off the end of the cliff with your argument and say, follow me, right? I'm not going there, right? It's all about understanding your condition, doing a lot of the reading and critical thinking on the outside before you get into writing the paper. That's, will save you that aggravation. So, all right, let's talk about that scoliosis thing for a minute. So, bracing has traditionally been a treatment, and we know that there's different types of braces out there for scoliosis. Are there other types of treatments?
Physical therapy, there's massage therapy.
Wouldn't we do those with bracing though? Why would we separate them?
Yeah.
Okay, so we're going to probably have combinations of physical therapy, massage therapy, or whatever else with a bracing technique, right?
Yeah.
So now comes the question, right? What's causing the outcome here? Is it physical therapy? Is it bracing? At what point in time do the effects of bracing, become limited, and where does physical therapy pick up and bring that forward, right? So we could start asking some questions about that. If physical therapy is doing a good job, maybe physical therapy is a treatment unto itself, right? But I'm probably pretty certain in my mind that it probably doesn't do the job enough on its own. Like, that's the reason why bracing exists, right? Because if you don't have to wear a brace, why would you, right? So think about this. That comment right there, if you don't have to wear a brace, why would you? There's a compliance factor in that, right? Because people aren't going to want to wear a brace around, especially at that age, right, where they have those kind of insecurities. So there's a factor of compliance. Sure, I get it. Maybe some people won't want to wear the brace. There's different types of braces out there. Why are there different types of braces? It's another question to ask. Anybody know why there's different types of braces? It's made of different materials. Probably because the braces that we currently have aren't effective, right? Or maybe they only get 50% efficacy rates or something. I don't know. But it's certainly a question to ask, right? If you see that there's multiple types of braces out there. Well, it must mean if there was a good brace, then we wouldn't need an alternative, right? None would be invented. We would just say, hey, we got our answer over here. So because there are multiple braces, there probably means that the ones that we got are inconsistent. Okay, why are they inconsistent? Is it because of the condition? Is it because of the compliance factor? Is it a comfort factor? Or is it because of an efficacy factor? Is it not get the job done? Ask the questions, guys. Just constantly be thinking, where's the problem in this?
Because those one day, not really issues with doing like the acute low back pain, because no one, a lot of people, if they have back pain, they're going back, we take the NSAIDs. So trying to differentiate between which is the most like efficacious treatment, you're looking at some alternative things, acupuncture like that. A lot of times people are going to take it. So normally if someone's going to physical therapy, they're already taking NSAIDs. So
yeah,
it's like, which is more effective?
And that begs the question, is there a pharmaceutical approach? I mean, if you're just dealing with low back pain, though, I mean, look, we can control pain very easily with high-powered pharmaceuticals, right? But are we treating the condition? That's, you know, if you've got some kind of muscle imbalance, right, then obviously just throwing a bunch of high-powered painkillers at it isn't going to fix the muscle imbalance. So you got to have something else on top of that, right? So, but with scoliosis, you're talking about, you know, the malformation of the spine. The curvature is greater than what we expect to be normal, right? So, if that produces pain, low back pain in some way, right? I mean, hitting it with high-powered anti-inflammatories, pain medication, whatever, doesn't fix the spine angle, right? So all those things are as adjunctive treatments to help manage the condition, right? We would probably be worried more about, you know, the fact that, okay, pain is a factor in here because of just the way the condition operates, right? But it's not going to be the most important factor because spine angle is going to be the thing that would reduce it if we fix that first. So that's going to draw more attention to, I mean, this is the reason why you've got to be doing the critical thinking here, right? Your operational definition, those criteria in that operational definition, some are going to be more valuable than others. You need to emphasize some over others. Other ideas? Other questions? Other things to think about? I'm happy to answer any of the questions or talk about. If you've got an idea, let's talk about it, because the more you talk about it, the better off your critical thinking becomes.
And that's also playing around with the idea of like ACL tears, but just knowing that it's a finite like surgical option because most of the
right, and you're not going to be surgeons, right? I mean, if you wanted to do something but ACL rehab, sure, there's different methods and mechanisms, modalities for ACL repair rehab. Sure, go into that. And I would think that a lot of that is going to be dependent on the type of surgery that was performed, right? Because if you're using, you know, a replacement tendon or something like that, they're going to have greater tensile strength. Some are going to have greater tensile strength than others, right? The mechanism of suturing, you know, may have a greater rate of re-tear than others, right? So if you are dealing with a rehab protocol and you're getting bad results, are the bad results due to the rehab protocol or to the surgical outcomes? It's a good question, right? We don't often know. So I would think that, you know, I know there's a ACL tear, I mean, all sorts of ligament tears and those kind of things. I mean, you're not doing surgeries, but you're doing the rehab. So let's look at all the different rehab protocols that are out there and figure out who can get better outcomes. Or, you know, and I mean, I think about this, even if you want to do this with like sports performance, right? Let's say you want to get somebody to, you know, jump higher, right? I mean, could we produce, I mean, let's say your whole thing is you want to be in, you know, like the in athletics, like be a PT, in an athletic environment or something like that. And sports performance becomes part of your duties and responsibilities. Not only are you doing the rehab stuff, but you're also getting people. If you need someone to jump higher, run faster, or do something like that, are there certain training mechanisms that could produce that for you? I know that's more relevant to athletic training, but it certainly is in the purview of physical therapists sometimes when they're dealing with people who are trying to recover from something, but also in the process of recovering, it's not about getting them back to normal, it's about getting them to be trained in their sport. That's certainly something to think about. Anything else? Yep.
Concussion rehabilitation.
That's a tough one.
Yeah.
I mean, I'm not trying to discourage you from going in that direction, but I mean, let's just be honest, right? We don't know a whole lot about concussions right now, right? And you've probably seen it. I know I've seen it. I mean, I've seen kids run headlong into a goalpost, get up and walk away and not have any problems. I've seen other kids get hit with a spit wad and, have to be confined in a room for 6 weeks, and can't be exposed to light, right? I mean, it's amazing how different the brain reacts, right, to, different levels of impact. And that's the variable, I think, that we cannot control, because without doing brain scans on our patients, how are we supposed to know the level of injury that people have incurred, right? I mean, there are $1 million grants out there all over the place to study concussions. And the other thing is that, Keith, I mean, if you think about this is really kind of an interesting one. A lot of times what we do is we just base it on cognitive functioning, right? And there's a bunch of different little computer tests out there, right? So here's a great example of what of something like that. So we were involved with a concussion protocol study here. I connected with some guys down at the Harbor Center, and we were studying youth hockey players and gathering data on kids between the ages of 8 and 12, and trying to evaluate when they had concussion or when they had a conk on the head or something like that, did it change their cognitive functioning? And Dr. Letty, who's over here at UB, who's the world's greatest authority on all this stuff. I mean, here we put forth this whole program. We bought this computer program. We had our protocol set up. We had our methods and everything. We were pretty much getting ready to run with this. And we made a phone call over to Dr. Letty, and we were using this this cognitive assessment tool from the University of Pittsburgh. We were doing some vestibular things too, right? I mean, we had force plates and stuff, and our physical therapists were measuring, balance based on, that. We're having the kids walk and run across these force plates so we know what, where their weight is being distributed, those kind of things. But when one of our researchers contacted Dr. Letty over at UB and said, we're using this University of Pittsburgh, cognitive assessment form, and his question was, what are you doing that for? He's like, I don't think that's a reliable measure. We're just like, we just put all this time and money into setting up the study all around this cognitive measuring tool, and the world's greatest authority on it says that's not a reliable tool. And we were kind of just throwing our hands up in the air going, well, we don't know what we're talking about, right? And it was all because, I mean, he said that he uses a different tool, but even that has variability. And really, what does it measure? And without the baseline measures, how are we supposed to know what kind of changes we have? And that's the greatest thing to overcome, right? Is that we could look at someone and put them through a test and then see the changes on the test after they've been concussed. But if we don't know what their baseline measure is ahead of time, how do we know that the changes were relevant to getting them back to normal?
Most high schools, college, professional teams all do baseline pre-concussion.
Yeah. I know they're doing it now, right? But it's expensive too. I mean, you got to pay somebody to do it. Your school system has to be willing to pay someone to, do the testing and here's the other thing. So you base it, and this is why a lot of schools are finding out that it's not even worth the money to do it, because they're spending a bunch of time and money to conduct the test and get these measures, but what do they really mean? If they don't have validity, what are we collecting that data for?
Yeah, my buddy's the ET at Orchard Park, and before football season, they have to do all the testing and stuff. He actually finds that some kids will try to lower their.
That's right, yeah, they're manipulated.
I've heard, I'm an athletic trainer as well, I hear people say it all the time, so if I do bad on this.
Yeah,
Yeah.
right. And so there's another factor that you've got to deal with concussion. It's always about return to play, right? And, you know, you can only have so many physiologic measures, right? Unless we're doing brain scans, which are really expensive and time consuming, right? I mean, unless we're doing brain scans, we can't probably know exactly what's going on with people. And so they can lie and manipulate and, you know, cheat the system in order to get back into play. I mean, I understand that. I understand that it's part of, I mean, you can't control that. But with the tests and measures, you know, be able to override those manipulations. I don't know. I mean, it's a good question. But I'm just saying, I mean, you have your investigation is like stepping into a tornado of information, right? I mean, that you are just going to be overwhelmed with so many things going in so many different directions with so little validation. You're probably going to get really frustrated. I mean, it may be a good exercise for you. I mean, to go through that, to find out how meaningful a lot of that stuff is. So yeah, I mean, I would encourage you to do it, because I think you'll find that a lot of studies are going to be probably inconclusive in a lot of ways. Some of them are going to have more validity than others, and some of them are going to just kind of narrow in on a couple of issues that they're going to try to, you know, focus on. That's good, right? They can do that because that's what, you know, the research is trying to do, just chip away at it, like just get. I mean, here's another thing: is, you know, we don't even know how age affects concussions either. Right? I mean, I know that when we were doing our study, I talked to this guy at the University of Michigan who, you know, was saying, he's like, we don't even do testing on, you know, people below the age of 12 because their skull hasn't necessarily fused appropriately yet. You know, so, and here we were, our whole study was based on like 8 to 12-year-olds. He's like, and he's like, you're just opening up a completely different can of worms. He's like, we don't even have much research on that population. So I'm just warning you that variability is going to become your friend. Okay? I mean, that's what you're going to have to get used to, is that there's just going to be a bunch of ideas going in a lot of different directions, which, you know, it's okay. It's what you got to deal with. Anything else? You have a week to write this paper, essentially, because it's due on Thursday, the 7th, which is the last day of class. Now, let me just give a warning to all those you and whoever's listening.
The 6th. The 6th is Thursday, the 7th is a Friday.
Oh, sorry, the 6th then. All right, and I made that mistake. Did I write that? Did I put that mistake wrong on the syllabus? Yes. Okay. Yeah. So, what is a? Yeah, a second. Let's look at the calendars to make sure that. Because if it's Friday the 7th, then we'll take it to Friday the 7th. But if it's not, then what's all right, final exams held on the 7th. So so we do have until the 7th to turn that in, because, well, I would say the 6th would be reasonable in case we have to do a final exam on the 7th. So why don't we shoot for the 6th? If you need time to turn it in on the 7th, you know, I'll grant you that time. But let's shoot for that. Now, I just want you to know, right? I mean, that we don't have any room for error on this one, right? So if your papers come in, you know, look, I dealt with papers that did not intend to put forth any effort to meet the standards of the AMA, right? I mean, sources that weren't in chronological order, references that didn't, you know, meet the standards of capitalization, abbreviations, and all those kind of things, right? I mean, you can't do that in this paper because I don't have any time to allow you to bounce back from that, right? So if you make those mistakes in this paper, it's going to be, you know, damaging probably to a point where you won't be able to pass the class, right? So make sure that you have the rules of the AMA and all of these issues secure, right? We went through it here in paper 4, so you should have a level of comfort so you know what to do with paper 5, right? You shouldn't have to be worried about asking you to count your sources, right? 1, 2, 3, right? I mean, your sources can't go 1, 4, 7, 10, right? They have to go 1, 2, 3, 4. So, I mean, my point is that there's no room for error on this last paper, right? So we've done it once, now we need to do it again. This one needs to come in squeaky clean. You want to talk about anything else before we wrap it up? Just understand, my main concerns were things. I mean, I can't help this, right? You can't read the manual and follow the instructions in there. I can't help you, right? But I can help you with things like how to evaluate your sources, how to correlate your sources. You got questions about any of that stuff, right? Send me a paragraph and just say, look, am I doing a good job with my analysis here? Does this make sense? Am I doing a good job correlating these sources? Is this how we need to kind of blend things together? I'd be happy to help you with any of those questions that you have. Whenever you get bogged down with that stuff, great. We won't have any class up until the due date. We're not planning on meeting again until the day of the papers due. If we have to have a final exam or something like that, I'll call for that. But at this point, I'm not planning on doing it. I'm planning to kind of put all our eggs in these baskets, right, of just running these papers. So I'll just work individually with you across email over the next week just to make sure that you're on the right track. I would get started on this immediately because, as you probably found out with paper 4, time gets away from you, right? When it takes a long time to read these things and really fully digest them in order to understand how to write about them. Okay, good. Now, if any of you have any other questions, want to stick around, I'll be happy to, stick around and answer those questions for you. But at this point, let's adjourn. We'll see you or hear from you just through email